And hello everyone, and welcome back to another Rafael Medina Subspecialty Virtual Morning Report. Today, our focus will be on cardiology, and for this, we have three amazing guests. As a case presenter, we have Dr. Rachel Ohman, who is currently a second-year cardiology fellow and a PGY5 at UCLA Health. She is from San Diego, who grew interested in medicine while being an undergraduate at the University of Chicago, and she completed medical school and residency training at UCLA, after which she nurtured her passion for medical education as a chief resident. And as a case discussant, we have, so our first case discussant is Dr. Nguyen, who is a non-invasive cardiologist and clinician educator at Olive View UCLA Medical Center in LA. She completed medical school and internal medicine residency at UCSF and cardiology fellowship at Stanford, serving as a chief fellow. And as our second case discussant, we have Dr. Pankayatselvan, who is currently a third-year cardiology fellow at UCLA, who graduated from University of New Mexico School of Medicine and completed residency at Beth Israel Deaconess Medical Center. Yeah, so before we start with the session, first of all, thank you so much for being here. I'm so excited for the session, and I would ask the three of you to tell us what you like to do outside of medicine and also just to introduce yourself to the listeners out there. Maybe you want to start, Rachel?
Sure. Thank you so much for the lovely introduction, and we're so excited to join tonight's session. I love exploring all parts of Los Angeles, especially with my husband and our 18-month-old daughter. Lately, we've been really enjoying taking her to the beach and going on hikes with her, as well as our big Rhodesian Ridgeback. So outdoor time is definitely my way to recharge in LA, as well as enjoying the great food.
Amazing. Then Dr. Kaylin?
Yes. Hey, I'm Nguyen. Thank you so much for the nice introduction. I grew up in Southern California, actually, but I just moved back here about a year ago. So I feel like I've been getting reintroduced to all the great things about LA. So I've been really, similarly to Rachel, I've been really enjoying spending time outdoors. I live pretty close to Griffith Park, so I've been really enjoying going on hikes there. And similarly, live pretty close to K-Town, so I've been enjoying checking out a lot of the food scene and food around this area as well.
And Dr. Varini?
Yeah, thank you. Thanks for having me. Hi, everyone. Just to echo Kaylin and Rachel, similar interests. I like being outdoors. I'm a big tennis fan, so I like playing tennis, going to the beach, trying new restaurants. It's all similar things.
And thank you so much for being here. I'm very excited for the session. And then just to be on time, then I will ask Deborah to share the screen so we can start with the first aliquot. So Rachel, whenever you are ready, you can start.
Great. Thanks so much, you guys. Let me just pull out my notes real quick. All right. Well, I'm really thrilled to be sharing this interesting case with everyone today, and I'll start off with our first aliquot. So our patient is a 53-year-old woman with a history of asthma who was sent to the emergency department from clinic for failure to thrive. The information we have is that she had been in her usual state until about 9 months ago, when she began to lose weight without a change in appetite or clear precipitant. Over the following months, she also began to note yellowing of her eyes and skin, together with a new abdominal distension. And so she comes into clinic for evaluation of these concerns, at this point with slightly less yellowing of her eyes and skin, but with ongoing abdominal distension, and with a total 45 pounds of unintentional weight loss over 9 months' time. She initially declines having any overt exertional dyspnea with her daily activities, but on further questioning, she does ultimately endorse a decrease in her activity tolerance. Now she can only walk a block or two, as compared to almost a year ago when she could walk over a mile without stopping. And this is making it really difficult for her to keep up with her 3 young children, especially because her husband is actually deployed abroad with the Navy. She denies any abdominal pain, just the distension, and also denies any nausea, hematemesis, or confusion. She denies any chest pain, orthopnea, paroxysmal nocturnal dyspnea, or edema of the legs. Ultimately, her symptoms, the severe unintentional weight loss, and her functional impairment with some concern for failure to thrive, is what prompted the clinic team to send her to the emergency department.
Thank you so much, Rachel. So summarizing, we have a 53-year-old lady presenting with unintentional weight loss, jaundice, new abdominal distension, and exertional dyspnea. And then with all these initial case presentation, Kaylin and Varini, what comes into your mind? Maybe Kaylin, do you want to start first? I think you're muted. You're still muted?
Okay, how about now?
Yeah, amazing.
Okay. So 53-year-old with failure to thrive, I think failure to thrive is a pretty catch-all term. So I usually try to sparse it down into kind of what, you know, I don't think it helps us too much with our problem presentation. So I try to think about kind of what are the key things we're noticing here. So it sounds like unintentional weight loss that's been going on for 9 months. As well as some decreased functional status. So I guess in thinking about unintentional weight loss, I think that's usually a good place to start. Something I always worry about would be something like malignancy, autoimmune or other chronic inflammatory states could do it, like some kind of vasculitis or something like that. There are kind of chronic infectious etiologies that can do it as well. So I think those are the things that I'd be thinking about for her. Other things besides the weight loss, we see the yellowing skin. And so with someone with abdominal distension, I'd be worried about kind of what's going on, with her liver enzymes, what's going on, kind of going back to the concern for malignancy. I'd be wondering, does she have some kind of GI malignancy? Is there like a pancreatic malignancy? Does she have reasons why she has obstructive jaundice? And then with abdominal distension, certainly that could be in the setting of, liver disease, cirrhosis, but other things I think about with with signs of volume overload or distension with things like renal failure, heart failure. It seems like it's pretty, localized to the abdominal distension. We haven't seen a lot of signs that she has kind of signs of total body volume up, other than maybe the worsening dyspnea, but dyspnea is a pretty broad category, and it could represent a lot of things. So I think those would be kind of the main things I'd be thinking off up the bat. And I'd be really kind of interested to see how her vital signs and exams look and some of the basic labs for her.
Thanks so much for your reasoning, sharing. And Varini?
Yeah, I don't have much other to add, than what Kaylin had already said. Interested to see kind of, in terms of her family history, what's there, like, if there's any rheumatologic things going on, like exactly like family history of malignancies, things like that. But I agree. I think it sounds somewhat right now pretty localized to maybe like liver wise, just because she's denying like orthopnea, things that more towards left-sided volume overload picture. So yeah, I don't really have anything else to add currently.
And thank you so much, you both. Then Rachel, the stage is yours.
And should I move on to the next aliquot then, Shema?
Yes, please.
Okay, excellent. Just to confirm. Okay, great. So a little more information for you, because I realized everything I gave you was pretty broad. So for some additional history, she really doesn't have actually any prior medical history outside of this reported adult onset asthma with which she was diagnosed about a year ago. And she has no notable family history in any first-degree relatives, no history of substance use, inclusive of tobacco, alcohol, or any other drugs. And from a social history perspective, I had mentioned some briefly that she's a mother, a former teacher who's now working to take care of her 3 children at home. I'm getting some support from her family members, sisters, and mother while her husband is deployed abroad. So for some objective data, on her presentation to the ED, her blood pressure was 92/70, her pulse 77, her respiratory rate 18, with an O2 sat of 97%, and a temperature of 37.2. And in terms of our exam, she is clearly cachectic from visual inspection, though in no distress whatsoever. She's comfortable appearing. She does have some mild scleral icterus with moist mucous membranes and some mild jaundice under her tongue. On cardiac exam, she has a regular rate and rhythm with no appreciable murmurs, but her jugulus venous pressure is visualized to about 13 centimeters of water. And it was actually also noted by the admitting medicine team that her JVP would increase in prominence with the inspiratory phase of each breath. On auscultation of her lungs, those were clear without any adventitious sounds. Her abdomen is indeed moderately distended, but soft, and she has only trace pitting lower extremity edema. And on neurologic assessment, she's ANO ×4, alert and oriented ×4, to person, place, self, and situation. And she has no focal deficits and no asterixis.
Thank you so much, Rachel. Then I would ask you first, Varini, how would you interpret these physical exam findings?
Yeah, definitely. So I think she wasn't tachycardic. Her pulse pressure, she doesn't really have a wide pulse pressure per se. It's more on the narrow side. She's a little bit tachypnic. So huge things that I see, cachexia, her scleral icterus, and then interestingly, her cardiovascular exam is interesting, especially when Rachel pointed out that her JVP would increase on inspiration, like Kussmaul's sign, you always think about that. So that's starting to make me think of like constrictive pericarditis, like what's her history? Does she, was she ever, like, where did she grow up? Was she exposed, I don't know, to tuberculosis, have any radiation in the past, things like that could have caused pericardial thickening. And sounds like, from her history from no orthopnea, her lungs are clear, so that kind of adds up as well. But starting to think about constriction, but also like right-sided etiologies as well. So causes of right-sided volume overload, maybe she has pulmonary hypertension, things like that.
Amazing reasoning sharing. And Dr. Kalen, what would you like to say about the case so far?
Yeah, I agree with Varini. I think those are really good points that she brought up. I mean, the pulse pressure being narrow, I think when we think about cirrhosis, usually you think that they're pretty vasoplegic. And so kind of noticing that narrow pulse pressure, that's not really congruent with what we were kind of thinking with more kind of hepatic causes as the primary driver, and kind of really focusing in on the, the JVD as well as the increase with inspiration. And I agree, you're really thinking, is there some kind of constrictive process going on, some kind of pericardial process going on, and maybe she has some of these liver findings are secondary to a primary cardiac stuff. I mean, I think we also have the benefit of this being a cardiac case, but I think those are really good things that Ryan picked up on.
Thank you so much. And what I also wanted to ask you is, in terms of things like heart failure, as you pointed out, the patient has some signs of some congestion, so with the edema, and that's why I also want to ask you is, when we talk about things like right heart failure, what are the major causes we always have to think about? Because for me, as a non-cardiologist, I wonder what we always have to think about if someone is presenting with acute right heart failure in contrast to chronic right heart failure. So when you see this case presentation, would you say this is rather more something like a chronic process that triggered this presentation or something acute?
Yeah, so I think the timing really does help you here. It sounds like these symptoms have been going on. It sounds like progressively for 9 months. And she doesn't have evidence that, it doesn't just based on the clinical story, it sounds like it's a bit more chronic. I think when I think about right-sided heart failures, I think the differential is pretty broad. I mean, your right-sided pressures could be high because your left-sided pressures are high. And that's typically what we can see with chronic cases. And then other things you would think about are pulmonary hypertension for a multitude of reasons. There's a whole differential for that. In the acute setting, you're really thinking about things like PE can be a reason for that. And so, sorry, what was the other part of your question? So etiology, and then what in terms of what else do you have to think about?
Exactly. So when it comes to the causes for right heart failure, so what we always have to think about.
Oh yeah. So I think in the acute setting, I think we really think about things like PE. You think about anything that can increase their afterload on the RV side. So those could be things coming from the left. It could be things that are primary from the pulmonary vasculature. People can have primary tricuspid valve issues. So if they have, TR, if they're drug users and they have risk factors for endocarditis. So I think getting a pretty thorough kind of history of what are their risk factors and particularly their social history as well can be really helpful.
And before we get the next aliquot, what would be interesting for me, so what kind of diagnostic workup would you like to do, especially when this patient is presenting to you in the cardiology ward?
Yeah, maybe we'll let Bryony, do you want to?
Yeah, for sure. Well, I think just first basic labs, kind of just like what Rachel has there pretty much on the screen. Maybe put in like a BNP, other things, an echo, EKG, chest x-ray, all of those things that are basically in there to start with.
Amazing, thank you. And Kaylin, is there also anything else you would like to order or would you like to know from Rachel?
Yeah, I mean, I agree. I think basic, the labs, CBC, complete metabolic panel, BNP, we always like to get an EKG. And I think with this story, getting an echo, chest x-ray, I think the basic kind of workup there.
Thank you so much. Then Rachel, we are excited for the next aliquot.
Excellent. Loving the discussion so far. All right. So in terms of the objective information you requested, in regards to her labs, let's start there. For her CBC, her white count was 5.6, hemoglobin 14.2, platelets 123, with a diff notable for an absolute eosinophil count of 1,200. Her BMP, or basic metabolic panel, is 136 for the sodium, potassium 4.1, chloride 106, bicarb 26, BUN of 15, creatinine of 0.81, and a sugar or glucose of 102, with a magnesium of 1.8. For her LFTs, her AST was 45, ALT 36, alk phos 88. T-Billy was elevated at 3.1 with a conjugated Billy of 0.7 and her INR 1.3. Her troponin times 2 were low, intraderminant and flat. So on a high sensitivity troponin, it was 14 and 17. And BNAN-CP was 86. She also had actually an ESR and CRP, both of which were negative. So let me just make sure we have all that information before I go through the diagnostics beyond the labs.
Okay, thank you so much, Rachel. So starting, I would say, first of all, with the complete blood count. So the patient seems to have thrombopenia and an elevated eosinophil count. Then I would ask you, Kaylin, is there some kind of info that helps you to narrow down your differential?
Yeah, I mean, I think the EOs are interesting. I mean, I think, just thinking back to her adult onset asthma, and you wonder if it's related to hypereosinophilia. So wondering if, that's all related. I think certainly we can have eosinophilic myocarditis, and that would be a concern in someone who has hypereosinophilic syndrome. So I think, that certainly is concerning. And so, I think there's a differential for hyper EOs. There's, I think there's idiopathic once you've kind of ruled out other things, but you think about things like, I remember in medical school, there's like this NAACP mnemonic, which I can't really remember all of it right now, but it's like parasites, like autoimmune, neoplasms can do it. Help me out here. I think I got 3 of the 5. So we got so I think things like that. I think we want to rule out kind of what some of those things. And then you're left with like idiopathic hypereos in that situation. And so I think it'd be interesting to know a little bit, like Verini mentioned in the past, kind of her social history and what she's at risk for in terms of some of those other etiologies.
Amazing.
Yeah.
In terms of the thrombopenia, how would you explain that?
So, I mean, I think that's a pretty broad differential as well. I think it'd be good to kind of get, it'd be interesting to see what it looks like under the microscope. So to see what a peripheral smear would look like, to see if it's truly low platelets or if, there's something else going on. So, yeah, I don't know that I have like a super specific differential for that yet.
And Verini, would you like to interpret the rest of the labs?
Sure. So in regards to the chemistry panel, electrolytes look, relatively okay. Sodium, potassium, chloride, bicarbonate BUN, creatinine looks fine, mag, that's fine. Her LFTs are a bit elevated. And then I don't remember what her alk phos is there, but anyways, it does show, it seems like she has some hepatic injury from that. And then her bilirubin conjugated looks elevated. So there's probably, a direct component to it, meaning like intrinsic liver issues. Then her INR is also a bit elevated. So functionally wise, worried about, did the liver, has it take a hit over all this time? So probably some functional impairment. So going back along to the platelets, I think it could be from a variety of issues, but could be, secondary to the liver itself or maybe dilution a little bit, but I think it's broad from there. So it would be actually in terms of the imaging too, we should probably get a abdominal or liver ultrasound to add. In terms of the troponin, it's kind of flat. Obviously you need to correlate it with EKG, but it just looks probably like a myocardial injury type pattern. And then interesting that her ESR and CRP are negative. And I think I would have thought there'd be some mild elevation, if anything, just probably some inflammatory milieu going on.
Thank you so much. And Kaylin, do you have anything to add?
No, I think we covered it.
And another question I would like to ask is because you mentioned this whole bucket of hypereosinophilia and you came to talk about the patient's past medical history of asthma. So is there something you would also like to check regarding her past medical history and her eosinophilia?
Oh, Is that a leading question?
Yeah.
I mean, I think I'd be curious to see how the asthma was diagnosed. I mean, I think, yeah, I mean, I think in trying to put these things together, I mean, I think you can certainly see like, certain autoimmune disorders doing it. I don't remember specifically what the test would be for EGPA for this adult onset asthma.
And what I was also asking myself, because you already mentioned during your first aliquot something like congestive hepatopathy as the cause why this patient is being jaundiced secondary to right heart failure. Could the low platelets be also explained due to something like portal hypertension leading to hypersplenism, or I don't know.
Yeah, for sure. So, I think the INR looks like it's a little bit prolonged, the platelets. So you could certainly be seeing signs of synthetic dysfunction from the liver disease. Definitely. I mean, and I think, you know, I also is making sure we're not missing anything with the liver. So, like Rani mentioned, getting the liver and abdominal ultrasound, and especially in someone who's having this abdominal distension, makes sense.
Thank you so much. And what further tests would you like to do?
What next test would I like to do?
Yes.
Oh, I think we should get an echo and EKG.
Then, Rachel, would you like to give us, please, the next aliquot?
Yes, absolutely. I know my cardiology colleagues are wanting that additional cardiodiagnostic data too. So in regards to the additional info, I'll start just briefly with the chest x-ray. So chest x-ray was overall unremarkable, save for scant to small bilateral pleural effusions, but otherwise no parenchymal changes. In regards to her EKG, that just showed normal sinus rhythm with nonspecific T wave changes. And for her echo, that demonstrated low normal biventricular function with an EF of 50 to 55%, a TAPSE of 1.7 centimeters, a severely elevated estimated right atrial pressure of 15 millimeters of mercury, but ultimately no wall motion abnormalities and no significant valvular disease. I'll just note that this was a standard echo without other specific hemodynamic assessments, but the summary is that there was the EF of 50 to 55%, the TAPSE of 1.7, the RA pressure of 15 millimeters mercury, but no significant valvular disease or other abnormal findings on a standard echo. She did also get an abdominal ultrasound, which showed some hepatomegaly with moderate volume ascites. And those findings altogether, especially the abdominal ultrasound with the ascites, prompted her undergoing a diagnostic and therapeutic paracentesis. She, from that sample, did have a serum albumin ascites gradient or SAG that was measured and ultimately was not helpful because it was 1.1, which is right at the cutoff of determining whether the ascites is suggestive of being from portal hypertension or not. But there was nothing that grew out from the acidic fluid. And so despite those findings for the ongoing concern for hepatic disease, she actually then underwent a liver biopsy, which confirmed the congestive hepatopathy, but showed no fibrosis, meaning there was no evidence of cirrhosis, just the congestive hepatopathy. And I'll stop there for now.
So then asking you both, with these new information, is there anything that helps you to narrow down your differential or helps you with your working diagnosis?
I think for me, Rachel, if the echo gave an RVSP or commented at all on the pericardium,
I'm so sorry. I left that out. My apologies. It was in my notes. So I mentioned that the RE pressure was 15. RVSP was 37. There was not any comment on the pericardium outside of that. There was no evidence of a pericardial effusion.
Okay. Yeah, so that's interesting. Her RVSP is not too, it's not too high. Normally I think of like around 40, but it's kind of ruling out, pulmonary hypertension cause. And if she didn't really have signs of constriction on her echo, like thick pericardium, annulus reversus, all those, extra things that we look up, it sounds like not. And no real valvular disease, it kind of, is ruling out some of that in some of our differentials that we were thinking about for kind of right-sided dysfunction.
Yeah, I think it'd be interesting to see if she had LVH on this. I mean, I think we're kind of honing in on, does she have some kind of hypereos, autoimmune disorder going on here? So I think kind of it sounds like her EF is pretty normal. We don't get an assessment of her diastolic dysfunction, but I think kind of just thinking about if she has, some either kind of restrictive, infiltrative, constrictive, like all the things we're thinking, like what is the reason that her, she has JVD in someone who has a low normal EF and elevated right atrial filling pressures. Her RVSP is not super high. We take that on face value. It's likely can be, yeah, it's not super elevated. I think RVSP can be underestimated on echo, but I think if we kind of believe that, it doesn't seem like it's enough of to cause RV failure. And it sounds like, she has low normal biventricular function, right? So she doesn't have significantly depressed function to explain why her RV is so high. So then you really start to wonder, is there some kind of diastolic dysfunction or kind of myocardial process that's causing her to be volume overloaded, or is the heart kind of just a innocent bystander in all of this? So I think that's always the question we ask. It sounds like she has a lot of ascites, a lot of fluid. It sounds like that's been kind of unrevealing so far. But it sounds like the other thing I always think about in these patients, if you are worried about a primary cardiac etiology, is if something, like a cardiac MRI would be helpful, where you can see evidence of fibrosis or edema. And she has normal renal function. I don't think she has any other contraindications. So that's something I would consider for her. And I noticed someone mentioned in the chat, getting ANCA. Okay, so that's the EGPA test that we want. So I think additional workup for autoimmune causes, maybe getting that room workup done. It is interesting that her ESR and CRP were negative, as Bryony mentioned in the past, but I think kind of going in on the cardiac stuff, thinking about a cardiac MRI for her.
Yeah, and then the one easy test that I forgot to mention we should order too is a UA. Should see if she has any protein loss, things like that. I think that's pretty telling a lot in all these, especially for these like autoimmune types of like ANCA cases. She's got any, nephritis going on, things like that.
Thank you so much. And another question would be for those of the students or still learners that are not that familiar with interpreting a heart echo. So especially if, I wanted to ask you is like, in terms of right-sided heart failure and with these things that have been mentioned in the echo findings, so how can we summarize it just as a general understanding? Because you mentioned things like how I understood pulmonary hypertension is not likely. So the question would be, what would be speaking for something like pulmonary hypertension? And so what do you think is at play right now, explaining the pathology here?
Okay, so I think in terms of how I think about the echo, common causes of RV dysfunction is LV dysfunction. And so you kind of have to interpret it in the context of that. So, you know, like I said, you know, for LV, you have systolic and then you have diastolic dysfunction. So it doesn't seem like she has, I mean, her LV is low normal, but it doesn't seem like she has significant systolic dysfunction, but we don't quite know if she has diastolic dysfunction. So that would be the other reason, like someone with like HFpEF, for example. So certainly, you know, you can have increased pulmonary pressures from as a result of that. So, you know, generally I think about my WHO classes. So with heart being the most common, so you want to think about any signs of heart disease for pulmonary hypertension, but then there's of course, you know, pulmonary causes, connective tissue, autoimmune causes. So the differential for that's broad. And then in terms of the RV, if you're like, hey, the LV is fine, but it looks like the RV is, you know, dysfunction is out of proportion, then there's a differential for that. In the case of this echo, you know, it looks like the biventricular systolic function is pretty normal, but we have, you know, a mildly elevated RVSP. I think, you know, over 35 is when you start to think it's a little bit elevated. And then you have, you know, a elevated right atrial pressure. So signs that she has, you know, we don't know exactly what the filling pressures are on the left side, but we know that she certainly has elevated right-sided pressures. So you want to get a sense on if that's because her left-sided pressures are elevated or not. In this case, we don't really know. And so these are the people who, if you really don't have an alternative etiology, you know, something like a, you know, getting the filling pressures like a right heart cath would be helpful. I don't think we're quite there yet with her, but I think we don't have much to go on just based on the echo here. We're not seeing super high RVSP. We're not seeing signs of LV dysfunctions. We're not seeing signs of pericardial disease. You know, the RV doesn't look like it's super dysfunctional. So there's not, you know, I mean, overall, other than having an elevated right atrial pressure and a mildly elevated RVSP, there's not much that's too remarkable about this EKG. So in someone who didn't have this history, I would say it would be, you know, not much to really hang your hat on here.
And thank you so much. And Varini, do you have anything to add?
No, Dr. Nguyen teaches me, so that was a fantastic echo overview.
And then I would like to ask you both, what would be your next step in terms of the further process?
You know, I think in terms of just, I guess, kind of just summarizing where we are on the case so far, because we've had a lot of information. So we have, you know, I think we have this middle-aged woman who has this chronic course of weight loss, as well as worsening dyspnea. It sounds like some jaundice, scleral icterus, who comes in with signs of you know, abdominal distension, elevated JVD, and whose workup has been notable for, you know, hyper EOs, as well as low platelets, elevated signs of liver dysfunction, as well as, but pretty unremarkable inflammatory markers with a pretty, I mean, elevated right atrial pressure on echo, but otherwise a pretty unremarkable echo. Has signs of, you know, ascites, which we kind of expected, but not much that's really else to hang our hat on, right? So I think the things that really that we really have are these high EOs. So we have this adult onset asthma. So we're really thinking, is this autoimmune, which would fit with kind of the time course, some kind of, you know, autoimmune or rheumatic etiology. Are there, you know, infectious etiologies that could do this? Probably, you know, like, again, with the social history, we don't know if there's any parasites at play here. Are there any neoplastic things that could do this? So I would be really thinking about, you know, kind of our room, our infectious and our neoplastic etiologies. You know, I think, and in thinking of those things, I mean, we can think for autoimmune, we can send the rest of the rheumatologic markers, ANCA being one of them. I'm sure there are many more that we could send to kind of narrow that down. We could always get our I feel like at this point we just ask rheumatology for some help in terms of what things to send there. I think, in patients who come in with this weight loss, chances are they're going to get a CT scan and make sure there's no underlying malignancy there, especially with the in the abdomen. And, I'd argue, probably this is someone who would get CT-AP'd as well. And then just, thinking about any other infectious things, any other parasites, any risk factors there for infectious etiologies.
Thank you so much. And there was another question being asked regarding echo findings. So the question is, I have to find it, just a moment. So the question is there anything in echo findings that can lead us to what the diastolic function was like?
Yeah, I mean, you can do diastology, or we do diastology on echo, and so you get a sense of the relaxation and the filling pressures on echo, and so usually they will, in the echo report, give you either an estimate of diastolic function, or tell you that it's indeterminate or there's some severity there but not able to grade. So we do assess that on echo. Yeah. And then there's also other signs that make you think of it, right? Like if someone has a lot of LVH or other or signs that they have elevated left atrial pressures and things like that, those can be suggestive. But we do assess kind of the LV relaxation, the filling pressures, as well as other signs of remodeling as a result of diastolic dysfunction.
And I'll just jump in and add that fortunately or unfortunately, this patient's diastolic dysfunction was indeterminate, and there was no significant hypertrophy or LVH.
Thank you so much for the 2 points. Then, Rachel, would you like to give us the next aliquot, please?
Yes, I'd love to. Okay, so for our next aliquot of info, just as Kaylin and Bryony were discussing, further imaging was pursued ultimately with this patient's constellation of symptoms and objective data. So she did undergo a CTA as well as a CT abdomen pelvis. The CTA did not show any PE, but did show some calcified pulmonary nodules. And then her CT abdomen pelvis demonstrated omental thickening or thickening of the omentum, right, the peritoneal lining. So those are the two main findings, the calcified pulmonary nodules and then the thickening of the omentum. That omental thickening prompted a pelvic ultrasound, which showed some fluid in the pelvic region, but no adnexal mass or mass of the ovaries. Based on these findings, there was rising concern for malignancy or atypical infection. And so IR, or interventional radiology, was consulted so that the patient could undergo a biopsy of the omentum or the peritoneal lining. That ultimately demonstrated a lymphoplasmocytic infiltrate without any evidence of dysplasia or malignancy. And this, microbial stains and cultures all were negative for infection, including a mycobacterial stain, which was of particular importance given some concern for tuberculosis with the calcified nodules. As the diagnostic workup continued, an endometrial biopsy was also actually performed because of the CT findings, and that too was negative for malignancy. So ultimately, all of the workup being relatively negative to date outside of the findings we discussed, there was one serologic test that was done and was found to be borderline elevated, and that was a serum IgG4 level. And so I'll continue with the kind of final piece of information before the next part of our discussion. So now, ultimately, with cirrhosis or hepatic dysfunction, primary hepatic dysfunction being lower on the differential, malignancy and infectious etiologies being lower on the differential, further cardiac workup was pursued as we were discussing, and a repeat limited echo was done to better evaluate for constrictive or restrictive physiology. And this full assessment of constrictive restrictive parameters actually did end up suggesting constrictive pericarditis with a high E prime, the elevated RA pressures that we mentioned, some septal bounce, and hepatic vein diastolic flow reversal seen in expiration. That limited echo kicked off the completion of a cardiac MRI, which did pick up on circumferential pericardial thickening up to a level of 4 millimeters, as well as confirmation of the septal bounce, enlargement of the IVC and SVC, and small bilateral pleural effusions. That was a
Rachel,
lot. Happy to repeat any of that.
thank you so much for this very enriching aliquot. So then I will leave the mic to Kayla and Varini to share their thoughts.
Yeah, I could go ahead and go. It sounds, like we've got a pretty thorough workup, and malignancy is not, so much on the differential anymore, especially after multiple biopsies. The only, thing that Rachel pointed out was the IgG4. To be honest, I'm trying to go back to my med school days on everything that IgG4 can cause and all of the issues. And at this point, and probably before I ordered anything else, that a room and probably hemonc consult would have already been ordered by me at least, to help parse out all of these things, especially just like Kaylin was saying, with the EOs being that high. So in terms of investigation further for IgG4 and what needs to be done with that, and kind of all the other syndromic processes, I'm curious. I don't know in specific IgG4 causes for cardiac issues, if it could cause a myocardial kind of process there. But it did seem like some type of pericardial, it affected the pericardium some way or another, enough to cause, this constrictive process that we were able to see on the echo after repeat and then MRI. So it does seem like, this person had kind of a full body type of process going on, and then the heart kind of got affected and secondary in that way, is how I'm thinking about it. But I don't know if Kaylin, if you have anything else there.
Yeah, I agree. I mean, it sounds like we have a constrictive pericarditis due to thickening of the pericardium, and it sounds like this is, the heart is involved in the systemic IgG4 related process that also involves the the GI tract and other things. So I think we can, in terms of how to approach this, I think there are certainly things we can do from a treatment perspective to help with the filling pressures and the ways we can manage the constrictive pericarditis. But I think treating the underlying cause is really what we are shooting for here.
Thank you so much. And one question that I would have is regarding the diagnosis of constrictive pericarditis. Just in terms of a question of terminology, like when we think of something like restrictive cardiomyopathy versus constrictive pericarditis, is there any way to differentiate these both entities?
Yeah, I can take a stab at it, and then maybe Kaylin can fill in the gaps. So on echo, yeah, you definitely can tell there's different signs of both. So restriction versus constriction. So for constriction, you're thinking of kind of this pericardial thickening that's not allowing the heart to fill fully in diastole. So with that, other than pericardial thickening, things like that, you look for signs of a septal bounce, like what Rachel had mentioned. So that's, once you look at echoes more and things like that, the septum will just be moving in a certain way. And that, septum issues come with a lot of different types of differentials, but specifically septal bounce is something that we think about for constriction. Other things you look at are also E prime. So with constriction, you get what's called annulus reversus. And so the heart, instead of being able to expand normally, like in diastole, so expand laterally, it kind of elongates instead. And your medial E prime, I think it's a little bit hard to go through kind of everything in this setting, but your medial E prime normally is slower than the lateral. In constriction, it's reversed. So we call that annulus reversus. And so when you see things like that, you're kind of curious. You can also see hepatic in your hepatic Doppler signal. During expiration, you'd see diastolic flow reversal is another thing, whereas for restriction, that happens, you'd see diastolic flow reversal during inspiration. So that's another thing to differentiate the two. And then just going back along the lines of E prime, for E prime in restrictive types of cardiac disease, E prime should typically, you're seeing a lower E prime typically, both on lateral and medial. Whereas like for constriction, you're seeing elevated medial E prime in comparison to lateral. So that's another clue. And then it's called annulus, I think paradoxus is another one. So in constriction, you're going to get an elevated E to E prime, kind of like what you see with restriction as well, but it's just paradoxical in the sense that your left-sided filling pressures don't have to always, your left-sided filling pressures aren't actually high, it's just that your E prime's high. So just a lot of cardiac, this is a lot of echo terms and saying there are many, several different parameters to differentiate restriction versus constriction. And so the ones that Rachel did hone in on were very kind of telltale signs for constriction.
Thanks for all these pearls, Variety. I learned so much. And Kaylin, would you like to add something? And another question would be then afterwards also in terms of the final diagnosis, whether you would perform something like a myocardial biopsy, or do you think that the general presentation of the case is sufficient enough to give the diagnosis of IgG4 related disease?
Yeah, so I think to talk about the restriction versus constriction, I think Variety did it perfectly. I think the kind of big picture to know is constriction is, pathophysiology. We think of it kind of like tamponade, right? It's the pericardium, it's thickened, so the heart cannot expand out the way that it normally would. But the actual, there are mixed pictures, of course, but when we're thinking about pure constrictions, the myocardium itself is okay. It's just that it's kind of trapped in this thickened, stiff pericardium. Whereas restrictive cardiomyopathies, we think about something like infiltrative diseases and things that are actually affecting the actual myocardium. And so with constriction, you'd expect to see poor relaxation on the lateral kind of side of the LV, but not the septal side, right? And so that's why you have that reversus, because it's going to the medial side will try to overcompensate for that lateral side there. Whereas for restrictive, you just have problems with the myocardium. So they're both going to be poorly relaxing. So those are kind of the big picture things. So there are certainly things that make you, the pathophysiology is different, although again, like I said, there are disease processes that cause a little bit of both, and so that can be a little bit tricky. And so there's certainly things on echo that we look for to try to differentiate, as well as the rest of the clinical picture. I think it's always tough with to answer your question about cardiac biopsy. I think it depends. Cardiac biopsy, it's an invasive procedure, of course, and generally we're biopsying on the RV side, right? We're going in through usually through the IJ or some other vein, and then you biopsy the RV. And so thinking a little bit about, is this something that's going to have patchy involvement? Is this something where we're biopsying is going to have a high yield? Is it going to be, if it's negative, is that going to really exclude it? Or if it's positive, if it's positive, it's generally helpful. And if it's negative, it may not always be, depending on what's involved and if we're sampling where the involvement is. So generally in systemic diseases like this, I think if there's a different area that we could biopsy, or something else where, we already see that we have elevated IgG for peripherally, and there's obviously other places of involvement. So if there's other, tissue to be biopsied, and everything kind of fits in, then I think you could we would say that this is cardiac involvement of this greater systemic. If you can't make a diagnosis or there's nowhere else to biopsy and it's going to change your management, then certainly we could consider it. But I think, usually for cardiac biopsy, I feel like the yield is generally not as high and there are lower risk places where you can biopsy.
Thank you so much, Kayla and Bryony. Then I will lead the mic to Rachel for the last aliquot.
Thanks so much, everyone, for that discussion, and very relevant to and related to the discussions that were happening on the wards with this patient when we had her. So as we all have been discussing, the suspicion for IgG4 related disease grew significantly based on the information that we have already from our cardio diagnostics and the serum IgG4 level. But our rheumatology colleagues really cautioned us on jumping to that diagnosis without pathologic confirmatory data. And so we then were able to ask the pathology team to actually do IgG4 staining on the omentum biopsy. And that initially showed an equivocal result, basically a 20% ratio of IgG4 to total IgG, which didn't quite meet definitive pathologic criteria. And so given the high clinical suspicion, but the biopsy results not quite being concordant, that led to a large interdisciplinary discussion on the risk benefits of pericardial biopsy, as Dr. Nguyen was walking us through. And ultimately, due to the concerns for the disease process potentially being patchy and the risks of pericardial biopsy being higher than the omentum, the pericardial biopsy was deferred, and instead IR did a second biopsy of the omentum. And that repeat biopsy actually was able to obtain a better sample, or rather, I should say, on that sample, it was ultimately diagnostic in that there were IgG4 plasma cells in a ratio of 30 to 40%, which meets the quantitative threshold criteria for pathologic evidence of IgG4 related disease. That's, of course, in congruence with the plasmalymphocytic infiltrates that we're seeing. And so that is what clinched the diagnosis of this being constrictive pericarditis as the manifestation of IgG4 related disease, with a particularly fascinating element being that she had no other evidence of visceral involvement on her imaging or other studies, but that it was really, at least as far as we could tell, in the pericardium. So for treatment, she was started on prednisone for her targeted treatment, and then also started on some oral diuretics for volume optimization. She actually was also evaluated by cardiac surgery for consideration of a pericardiectomy. But given her clinical stability and that, of course, also being of higher risk, the decision was made to first trial medical management and then only re-refer her to surgery if she failed that. So our patient was stabilized sufficiently that she was discharged for close outpatient follow-up, and she did okay initially, although she had only partial improvement in her symptoms. And so that's what prompted the rheumatology team to actually escalate her immunosuppressive therapy to rituximab, which is a monoclonal antibody, as we know. And it was after she was started on the rituximab together with the steroids that she clinically responded and felt significantly better, improved from a volume status perspective, but also improvement in her exertional dyspnea and her activity tolerance and quality of life without any need for a pericardiectomy.
Thank you so much, Rachel, for this amazing case. Just also wanted to ask you, like, how you solved this case, because this seems like a very, very complicated case. Like, I've never heard of constrictive pericarditis being caused by IgG4 related disease. That's why I also wanted to ask you, for example, in terms of her past medical history with the adult onset asthma, do you think that this was just a bystander or related to her case?
Yeah, that's a great question. So I guess I'll answer first the question about asthma. Ultimately, there was some suspicion that she may not truly have had asthma. She did not complete any PFTs while she was inpatient. We didn't have any copy of outpatient PFTs from her home healthcare system. And so both the cardiology and the medicine teams raised some kind of skepticism as to whether this was even truly a real diagnosis of asthma, raising the possibility of that actually perhaps being at the 12-month time point, the earliest manifestations of her feeling dyspneic from this ultimately process of pericarditis. But I think we won't know, of course, until she actually gets the PFTs to confirm. And then I guess to the latter point, oh, sorry, no, go ahead.
No, there was being referred to the next part.
Yes. In regards to how we came to this diagnosis, I think it was such a testament to the teamwork of multiple primary team members and consultant teams together, and really close collaboration initially between our medicine and cardiology colleagues. This was really a wonderful example of that collaboration, and then with insight from our other consultants involved in the case. But I really tried to shorten this, believe it or not. This patient actually was in a different healthcare system initially and then came to UCLA. And so it definitely took some time before the correct diagnosis was reached. Yeah, I think I'll stop. I'll pause there.
Thank you so much, Rachel. I learned so much. And then I will lead the mic to Kaylin and Varini for their final reflections on this case.
Sure, I can go first. I think, yeah, thanks so much, Rachel. This was a wonderful case. I think it's just a testament, like even, as far as you specialize in medicine, things like that. A lot of things come down to the basics, and just from the CBC itself, her EOs being 120 is kind of like a red flag into maybe thinking about other things like rheum, hemonc, things like that. And so really keeping a broad differential, and but also a systematic differential. I think just going through the case, it's easy to we definitely evolved in our thinking just from historically to physical exam, and then once things started to come out a bit more. So yeah, it was a great case in terms of disease, and just medical management thinking, and working together with all the consultants and such.
Yeah, I agree. Thanks so much, Rachel, for presenting, and thank you so much, Varini, for discussing this case. I think, yeah, it was just a great case, right? I think there's a lot of great cardiology, physiology, but then I think you really, the case really kind of comes together as you get all these other consultants and experts, and really having to kind of get more information and putting it all together. And so I think it's just a really rich case of so many different specialties coming together and having to think about the patient as a whole and how everything's relating. And so, yeah, this was really fun. Thanks so much for having us, and for everyone for joining us.
And thank you so much, Kaylin and Varini, for this amazing discussion. Thanks for being here. And then I will lead the mic to Rachel to say some reflections on this case, and also maybe she would also like to summarize her favorite teaching points of this whole case or the whole discussion for the listeners out there.
Of course. Thank you so much, Shema, and the rest of the Clinical Problem Solvers team for facilitating, and Varini and Kaylin for such a phenomenal discussion coming in completely cold. I gave them no help, and just really such a rich and robust discussion. I think it goes without saying that this case is fascinating from the zebra aspects, right? I mean, IgG4 related disease manifesting as isolated constrictive pericarditis. I think that awakens the nerd and passionate medicine lovers in all of us. But I will say that's actually not my favorite part of this case. My favorite part of this case is how it's such a good example of how we need to be sleuths and mystery solvers for certain disease processes in particular. And I think this is a really good example of how challenging it is to diagnose constrictive pericarditis in general, right? And I think this was such a humbling case for everyone on our team and the many physicians involved, because we zeroed in so quickly on the liver, as I think we all did. And then we were thinking about malignancy and atypical infection, but remembering that constrictive pericarditis may have more subtle manifestations from a cardiopulmonary perspective, at least on the clinical symptomatology. And so I would just invite all of us to think about constrictive pericarditis. If you have a patient who's presenting with cachexia and abdominal distension and ascites, we go through our more common etiologies first, but add constrictive pericarditis to your list, because we can be humbled by how challenging it is to diagnose. And then for the constrictive pericarditis etiologies as a subset, which Bryony had so quickly rattled off way earlier in the case, picking up on the co-small sign, adding to your list IgG4 related disease, though it's certainly not going to be our most common ones. But to be honest, that's really my favorite element of this case. And I invite you guys to take away those translatable and generalizable teaching points as well.
Then thank you so much, Rachel, Bryony, Kaylin, for this amazing session. And then I would say goodbye to everyone, and hopefully we will see you in another session soon. Then bye to everyone. Thank you so much.
Thank you.
Thank you.
Thanks much.
Bye.